mode.
Good afternoon, and welcome to the County Health Rankings Methods and Measures webinar. My name is Karen Odegaard, and I am a community coach with the County Health Rankings and Roadmaps program. Today you will hear from Abbey Cofsky, Senior Program Officer with the Robert Wood Johnson Foundation, Bridget Catlin, Director of the Rankings and Roadmaps program, and Amanda Jovaag, Data Lead for the Rankings. Before we get started, we wanted to just take a moment to get you oriented to the technology that we're using today. The GoToWebinar attendee interface is made up of two parts. On the left here, you can see the viewer window, which is where you'll see our screen during the presentation today. And on the right, you can see the control panel, which is where attendees can interact with us throughout our presentation. Because of the number of people we have on today's webinar, we will be answering questions via taking questions via that control panel there. So feel free to enter your questions in the control panel at any time, and we will answer questions toward the end of the webinar. While we have the privilege of talking with you today, we want to start by acknowledging that the County Health Rankings and Roadmaps program is the result of the contributions of many partners, including the Robert Wood Johnson Foundation, our colleagues here at the University of Wisconsin Population Health Institute, and the various partners who help us compile the rankings data and get the message out about rankings and roadmaps. Abbey Cofsky, Senior Program Officer with the Robert Wood Johnson Foundation, is here with us today and is going to give you a few opening remarks.
Thank you so much. This is Abbey Cofsky, and I, on behalf of the Robert Wood Johnson Foundation, want to share my welcome and want to share with you just how grateful we are to have so many folks that are engaged in the conversation about the county health rankings. For us at the Foundation, we've had the privilege of collaborating with the team at the University of Wisconsin Population Health Institute for over 5 years to produce the county health rankings as what has become a leading platform for how we are creating health in our communities across the nation. Just recently, the Robert Wood Johnson Foundation released a new strategic vision for our work to create health and improve the health care of all Americans. And as we did so, we have laid out this big, bold vision that we as a nation are really working to create a culture of health. A culture of health that will enable all of us to lead healthy lives, to make healthy choices. And we know that that work can't happen alone, and so we see this as a journey that we are on with communities, counties, and leaders all across the nation. And as we do so, the county health rankings really provide an important platform and an important tool as we think about how to create health, how to address the barriers to better health in our communities and counties and cities across the nation. So again, we are so grateful for the work of the team at the University of Wisconsin Population Health Institute for helping us and helping communities really see the power of this local data. So much so that we have recently recommitted our investment to the county health rankings. This is a tool that we see as critical to our work and our strategy, and are committed to funding it for at least the next 4 to 5 years and into the future. So with that, I want to turn it back over to my colleague, Bridget Catlin. And again, thank you for your time this afternoon.
Thank you very much, Abbey. Thankfully, we got what you have of your voice there, so thank you for those welcoming words, and welcome from me and the rest of us here at Wisconsin to you all. We are going to, I'm going to go to give a brief background about the county health rankings. I'm going to talk about what's new for this year and get into the nitty-gritty on our measures. And then for those of you who are new to the rankings, I will then go through some of the details surrounding how we put together the rankings and talk about some of the data issues. But for those of you who've been on this webinar before, feel free to jump off at that point because that material has been shared in the past. So as again I said, for those of you who are new to the rankings, I'm going to give you a very brief overview, but we do have other webinars where we jump into sort of the overall details of the Rankings and Roadmaps program coming up, and there will be more of those in the future. So this logic model just shows why we create the rankings, and our goal is to build a culture of health and create a healthier nation, county by county. And we do this by gathering data and then disseminating the rankings. And the media pays attention to us, and that, we hope, then encourages broad community engagement and use of the information that we have to provide. With the county health rankings, each county across the nation receives 2 rankings. They get one ranking for health outcomes, which reflects the current health of the community as compared to other communities within a particular state. And then they get a ranking for health factors. This is an estimate of what your future health is going to look like in your county. And so let me reiterate, the counties are only ranked in comparison and relative to other counties within a particular state. So what's new for 2014? What I'm going to show you now is a sneak preview of our updated website that will be released to the public on March 26th. Each year we freshen the website with updated data and then other tools and guidance to help communities move from data into action. And rankings are based on a model of population health that appears to, there we go, we have in front of us now. Our rankings are based on this model of population health. You see the health outcomes at the top in green, and then the health factors in the middle in blue. This year, for those of you who are paying close attention to our model, you'll see we've made a couple of improvements. We've added drug use to the alcohol use box that you see there to the right of health behaviors. We're recognizing the importance of talking about this issue. We don't have any measures here yet, but we are working towards that for the future. But the biggest change I'd like to point you to in this model is down at the bottom in the physical environment. In addition to the air and water quality measures that we've had in previous years, this time, for the first time, we're going to be adding some measures of housing and transit. And I'll talk more about those in more detail further on. And don't worry, for those of you who are very interested in our measures of the built environment, those measures are not gone, but since they're primarily intended to improve diet and exercise, we've moved them up to that section of the model. Because the truth is that we can do things in the built environment to address all of our factors, whether they be health behaviors, clinical care, social and economic factors, or the actual physical environment. Another improvement that you'll see on the website on March 26th is new state pages. On these pages, you'll be able to access the rankings for your state, all of the underlying data, as well as state-specific links to other sources of data and help for making your community healthier. One other change I'll mention is that we've renamed what we've been calling national benchmarks, and we've renamed that to be top U.S. performers. These numbers are based on the same calculation, but they're designed to give counties that are doing well within their state an idea of how the top 10% counties across the nation are doing for that measure. So it's the same data, just got a different name to it this year. And then one last big change for those of you who are really, we hope that this is a lot of you, those of you who are really focused and interested in moving from data to action, our Take Action cycle that you see in front of you there, where we have the steps in the process of making a community healthy around the outside, and in the middle we have these circles that represent many of the players who you can work with, partners, I shouldn't call them players, partners or stakeholders, but this year for the first time we've added community development and nonprofits. So we have specific guidance that we've added to the website to help encourage people in those lines of work to join in these activities. So with that, those are the overall big changes, but now I'm going to jump into the details and the guts of the measures for the county health rankings. First of all, I want to talk about how we select our measures. First of all, the things that we measure really have to reflect something that makes a difference to population health, and something that makes a difference that we actually can do something to improve. So the measures that we include have to address things that are actionable. We don't collect the original data ourselves. We use data that's collected by others. Wherever possible, we use measures that are recognized and used by other people, and we really try to strive for valid and reliable measures. That's very important to us. Since these are county health rankings, we use data that are available at the county level. Lots of people ask why we didn't include this measure or that measure, and often the reason is that that data is just not available at the county level. We also look for data that is free or low cost, and we use the most current data available prior to our release. I'm sure that some of you share our frustration with the time that it takes for some of the measures to become available, but that is out of our control. And then lastly, a key consideration for us is that we don't want to overwhelm people with hundreds of measures. Our experience has shown that fewer measures really turns out to be much better than having more measures. So what we do, having said that, each year we do selectively add a few measures. We are committed to keeping the same health outcomes measures every year. These are the measures that you see in front of you that measure the current health of our communities. We update them with additional data, years of data, as that becomes available. Otherwise, we have not made any changes to these measures for the past 5 years. For the health factors, we do add measures if we find that measures reflect a better data source or a better way of calculating a measure, or more importantly, if we think that they are really going to help us in our communication to communities about all the different factors that impact health. So decisions to add new measures have both a scientific component and also a communications aspect. So specifically within the health outcomes, since some of you are new to us, I will just quickly go over these measures. You can see that there are 5 health outcome measures. They're divided into length of life and quality of life, and we weight those 2 areas equally since we believe length and quality of life are equally important. For length of life, we measure premature death, and to be more precise, years of potential life lost. This measure is central to our work because it carries the entire weight for length of life. This data originates from death certificate information. It is based on deaths prior to age 75 with the belief that deaths under the age of 75 are premature and that many of them could be prevented. We also look at 4 measures of quality of life. We look at low birth weight, which we give a weight of 20%. This comes to us from data collected by the National Center for Health Statistics from birth certificate data. And then we use 3 other measures that come from the Behavioral Risk Factor Surveillance System that CDC has calculated measures for us at the county level. And these measures reflect 3 questions that are asked of individuals regarding how they feel about their health, whether or not they're in poor or fair health, how many days in the past 30 have they felt physically unhealthy, and how many days have they felt mentally unhealthy. We include these to stress the importance of quality of life and the importance of both physical and mental health. So this is the core set of measures that we're committed to keeping the same over time, so you'll be able to use these to track your community's health status. Now we're moving on to the health behaviors section of our model. And here we include measures in 4 areas: tobacco use, diet and exercise, alcohol and drug use. That slide should have been updated, I realize, and sexual activity. And we are continuing to use the same measures in most of these areas, but you'll see highlighted in orange the areas where something is changing for 2014. Adult smoking is staying the same, but under diet and exercise, you will see some additions. We have updated data on the 2 measures that we've used in the past on obesity and physical inactivity. But as I mentioned earlier, we've moved a couple of measures here that reflect building environments that support healthy living. So one of these somewhat new measures is an index about the food environment. It combines last year's measure of limited access to healthy food with a measure of food insecurity. And it's the Food Environment Index is a measure that's ranging from 0, which is the worst value, to 10, which is the best value. And it equally weights the access to healthy foods and food insecurity. We have also created a new measure that reflects access to exercise opportunities, combining our measure of recreational facilities that we've used in the past with a measure of park availability. And so the measure reflects the percent of the population with adequate access to locations for physical activity, either through parks or at paid recreational facilities. We're excited about this measure. We think this is a great contribution, and we look forward to hearing your feedback once you all start looking at this data and using it. If you want additional details about the specifications on these, we can provide that at the end if time permits. Moving on to clinical care, again, the changes are in orange. So we will continue to report on levels of uninsurance, and we also will continue to report on primary care physicians, and that includes both doctors of osteopathy and MDs that practice in family medicine, internal medicine, and pediatrics, which is a definition that's in alignment with the Health Resources and Services Administration, which is where that data comes from. We also in recent years added a measure of dentists, which comes from a similar data source and reflects the total population for each dentist in the county. So we realized, though, that when we're talking about the fundamental, primary, and basic needs of communities, that we really needed to be paying more attention to mental health, and so we added this year for the first time a measure of mental health providers, and this measure will represent the ratio of the county population to the number of mental health providers, and that includes psychiatrists, psychologists, licensed clinical social workers, counselors, and advanced practice nurses specializing in mental health care. So we're again excited to be able to add that to the other healthcare providers that we have reported on previously. And then access to care is obviously very important, but so is quality of care. And so here we are going to continue to provide county-level estimates for 3 different areas, courtesy of the Dartmouth Institute. And those measures reflect hospital stays that could be prevented, diabetic screening, and mammography screening. So a note about these measures. So these measures report on the quality of care for the population over the age of 65. Dartmouth is relying on Medicare claims data to construct these measures. But we have been working with some colleagues at the Louisiana Public Health Institute who've been taking a more in-depth look at these measures in a couple of states. And they've compared rates for the Medicare population for these measures with those in the general population. And their preliminary results are telling us that the quality of the care provided to the Medicare population is very reflective of the care provided to other ages as well. We don't have access to this data for every state in the nation, but this is reassuring to us to hear that, yes, these are very strongly associated, the quality of care for the elderly population versus the quality of care provided to others in the community. So moving on now from clinical care to talk about social and economic factors. If you'll recall from our model, this is the section that actually has the highest weight overall. We assign a weight of 40% to our measures of social and economic factors, and we divide those into the 5 areas that you see here. Education, employment, and income each get a weight of 10%, and then family and social support and community safety each have a weight of 5%. And we just made a couple of smaller changes here this year. Rather than collecting high school graduation rates directly from states as we did last year, we've determined that the data from the National Center for Education Statistics is as good, and so we will be providing that. And this measure tells us what percentage of students that started in school in 9th grade graduated in 4 years. And the upside of this change is that now these data are a little more comparable than they used to be from state to state. Also in education, we looked at some college among 25 to 44-year-olds, and we have the age limit there because we think it's more realistic that 25 to 44-year-olds might possibly return to school and be able to gain more education. So we believe that that is a more actionable measure than if we just reported on those 25 and over with no upper limit. Elsewhere in the social and economic factors, keep in mind that it takes longer for the Bureau of Labor Statistics to produce county-level unemployment estimates. And so the rates that we are able to provide at the county level are not going to be as current as data that you may see being reported at the national or state level. Children in poverty is another key measure for us. And then in family and social support, we look at the percentage of adults reporting that they do not have adequate social support, and we also look at single-parent households. And then finally, within that section, in community safety, we're going to continue to report on violent crime data, but this year we're introducing an additional measure in this area for injury deaths. And this includes both accidents and intentional injuries. And many of these leading causes of injury mortality are preventable. And leading causes include motor vehicle traffic crashes, poisonings, drowning, unintentional falls. So we are pleased to be able to both add some data there, and then along with that, with our companion What Works for Health that looks at information about effective policies and programs, we've also been able to add information about injury prevention in that area too. So that's an important change to us. Now finally moving on to the physical environment. And as I said before, this is the area with the biggest changes. We are continuing with the same air and water quality measures, but we've introduced a new focus area called housing and transit. Our air quality measures continue to be the modeled estimates that we've had in the past of the average amount of fine particulate matter in the air, and then the drinking water violations measure estimates the proportion of a county's population whose water system has been affected by at least one health-related violation in the past year. But now, moving on to the new and exciting section that we've added, there's a lot of enthusiasm that we've already heard from the limited numbers of people that we've shared this with so far. You are by far the largest group to hear that we are adding housing and transit to the model. This is so critical. Housing and transportation have a very direct connection to health. And on our website, when we release in March 26, you'll be able to see we have some really nice write-ups that really get into talking about what the details are of the relationships between transportation and housing with health. But getting into the nitty-gritty of the measures today, because that's primarily why we're here to talk about that, the housing measure that we are going to use is one that we're calling it severe housing problems. And it is the percentage of households with at least one of 4 housing problems. And those problems could be either overcrowding, high housing costs, or lack of kitchen or plumbing facilities. And so a household is said to have a severe housing problem if they have any one or more of these 4 problems. In the area of transit and transportation, we have settled on a couple of measures that come from the American Community Survey. And one of those measures is driving alone to work. So it's the percent of the workforce that drives alone to work. Driving by yourself means that you are not using public transportation, you're not walking to the bus stop, walking between places. It means you're missing out on social interaction with other people and, of course, contributing to air pollution problems. So this is an important measure that, as I've just pointed out, has several implications for health. And then there's a supplement to that measure. The other measure sort of goes even further, because this is we call it long commute driving alone. And so this is among workers who commute in the car alone, the percentage that commute for more than 30 minutes. So again, that just sort of further exacerbates the kind of problems that I was talking about with driving alone. So that completes the, I know, very rapid overview of all of the measures. I do want to assure you all that for those measures that are exactly the same as in previous years, we do have very comprehensive documentation on the website about these measures. If you click on any measure, if you're on the website, there's a tab that gives a description of the measure and also talks about the methodology, about specifically how we calculate the measure. For new measures, obviously that's not yet up there, but that will become available when we release the website. So since we value your time, we wanted to let you know that the remainder of this webinar is going to involve issues that we have addressed in prior years. We will have a Q&A section at the end, and we will post answers to these questions that we get today. Because when we have a webinar of this size, we get far many questions than we are able to answer during the webinar, but we really do try to get to all of your questions. So if you have other important things to do and you already know about Z-scores and how we calculate the rankings, feel free to log off at this point. For those of you who are curious about how we actually calculate the rankings, I'm now going to do what we could call probably a very introductory statistics 101 about how we actually take all this wide variety of measures, put them all together, and produce rankings. So our overall approach goes like this. Here you see an example of the distribution of death rates, of premature death rates in Wisconsin for its 72 counties. And those of you who took an introductory statistics class will see that what looks like a relatively normal distribution of the actual rates. When we move to the next slide, now we have converted these premature death rates into what's called a Z-score. And a Z-score is a way of transforming different measures to a standard scale. And so what we do is we convert them based on the distribution, looking at the mean and both the standard deviation. And so every single measure, its value gets taken from whatever it was, be it a rate or a percent, and we convert them into these Z-scores. That puts all of our measurement onto a common scale that then allows us to combine them and do the calculations that we need in order to produce the rankings. So the only reason for the Z-scores, and from now on you don't even need to ever mention this again, it's just this way of transforming everything to put it on the same scale. So once we've done that, then we can move towards how we actually combine the rankings. And on this slide, you'll see that we carried over the values for a county, which happens to be our county here in Dane County. These are not current data, so if you're on the phone and listening from Dane County, please don't go reporting that this is your rate for this year, but this is just an example. But let's just say that Dane County had a rate of 4,800 for its premature death, and then that was then translated into a Z-score of negative 1.23. What we do with that value is then we apply the weights. And if you recall me saying early on that we weight length of life and quality of life equally, because premature death is the only measure that we have for length of life, that measure gets the 50% weight. So we take that Z-score, multiply it by 50%, and you see that value in the right column of negative 6.1. So we do the same transformation for each of the other measures. You'll see a measure on the value, the actual value, you'll see the z-score, and then you'll see the weight that's applied, and then you see in the final column that adjusted score. If we move on, we then have these adjusted scores that we sum up. For length of life, there's just the one, but for the quality of life, we summed up those adjusted scores, and then we end up with a composite outcome score of -0.71. We take all of the results for each of the county in a particular state, and we sort them, and we figure out the rank order. And the year that we did this example, Dane County ended up as 10th overall within Wisconsin for its health outcomes. Again, this is not current data. So that is how, so we do the same process with each of the measures. So regardless of how things are being counted, we can put them all into this common scale, we can apply the weights, and we can get these adjusted scores that we then use to rank. And with that, I will move on to talk about where we end up then. So we have all of these measures. We produce the two overall ranks for health outcomes and health factors, but we also produce ranks for these sub-areas too. So under health outcomes, we have a rank for that. We also have a rank for length of life and quality of life. And within health factors, we also have ranks for the 4 areas that you see there: health behaviors, clinical care, social and economic factors, and the physical environment. Now I'm going to, if that was all we had to do, our job would be much easier than it is. But unfortunately, there are a number of data issues and special situations that we need to take into consideration. As well as going through the steps that I just talked about, there are other things to be considered. One of those situations is that we do not always have all the data that we want for all of the counties for all of the measures. There are some counties across the nation where there just are not data available for them, mostly due to small population size within the counties. So for some counties, and it's not that many, I don't know the number this year, but it's under 100, we don't even have enough health outcomes data to rank those counties. So there are some number of counties that we are unable to produce ranks for. But for those where we do have sufficient health outcomes data, we still may have missing values for one or more of the measures. And what we do in those cases is, rather than dropping that county completely out of the rankings and missing out on a valuable opportunity to engage community members in discussions about improving our health, what we do is, to keep them in the rankings, is that we substitute in the state average or state mean for a particular measure in place of the missing values. This is by no means a perfect option, but we have pursued other ways of doing this and have landed upon this one as the easiest to explain, and one way that allows us to move forward and, as I said, calculate ranks for a county. Other issue that we have to consider is the reliability of our data. People often ask us about this. Data reliability really differs measure by measure. Some data comes from sources that are more reliable than others. For example, the National Center for Health Statistics and the Behavioral Risk Factor Surveillance System measures are calculated for us by the CDC, and the CDC only provides us with estimates that they consider to be reliable. And within that subset of the data that CDC provides to us is the premature death data, which comes from death certificates. And death certificates really provide a reliable count of deaths, which is what we use, but they may be less reliable in terms of when you look at specific causes of death. But as counts, they're very reliable. Other measures come from surveys rather than the death data, which applies to everybody who dies. For other measures, we base surveys for a sample of the population, and so those results may not be quite as reliable because you need to have sufficient people to be surveyed in order to get reliable responses. So we deal with this within the rankings in a couple of ways. one way that you'll see is that the more reliable a measure is, the more likely it is that that measure will have a higher weight associated within our calculations. And then for those measures that we know are less reliable, we do a couple of things to try and improve that reliability, such as combining multiple years of data for the survey measures, and we do that particularly, or CDC does this for us, particularly with the data that comes from the behavioral risk factor surveillance system. And they use up to 7 years of data in order to produce more reliable county level rates. And I want to mention a little more about this data too. Some of you who are on the webinar probably a couple of years ago, the CDC they claim and their sampling weights when they produce the behavioral risk factor surveillance system results. And what that did was that they added cell phone sample in, and then they changed the way that they did some weighting. But what has happened for the last couple of years since the CDC made this change is that CDC has continued to calculate these measures for us using their old methods to allow us to continue to look at them over time. They are working on a new method, and moving forward in the future, I believe that next year we will be reporting on a different approach to providing estimates for you from the behavioral risk factor surveillance system. Something else we do to address reliability is that we take a very close look at counties with outliers. And depending on the measure, we may truncate those Z-scores at a high level to make sure that the reason that a value is coming out as really high isn't just a factor of small population size and the variability that comes with that. And then finally, what we do is we encourage people when they're looking at our data to look at the measure results that we report on, but also to look at the confidence intervals, or error margins as we call them on the website. Whenever we have these error margins available for a measure, we report them on the website, and we encourage users to consider them when they're trying to evaluate whether or not whether there might be a particularly problematic area for a specific measure. And with that, we will begin to open it up for some question and answers. And I'm going to turn this over to my colleague, Karen, and she is going to read off questions either to myself or to my colleague, Amanda Jovaag, who is here with me. And Amanda will get the difficult questions, and I will get the easy ones.
Great. Thank you very much. Well, that was a lot of really helpful information, and we've had a number of great questions coming in. So I'm going to start off with a question for you, Bridget. Can we compare the rankings from year to year, and why or why not?
The ranks themselves are not really a good way to look at comparisons from year to year. Ranks are relative to for a county. If your rank has gone up or gone down, let's just say if your rank has improved, it could well mean that your health has improved, but it's also relative to the health of other counties in your state. So relying totally on a rank and looking for comparisons from year to year is not a good way of doing that. But what you can do is look at underlying measures and look at trends across time and make comparisons that way. So for measures that we have had all along, like the health outcome measures, you can look at last year's and the year before and see what's happening over time. And on our website, we are going to have special guidance for people as to how to do that and how to interpret these trends. So the answer to the question is that the ranks themselves are not a good way to compare from year to year. They are a tool to tell you how you're doing right now relative to other communities in your state, but please don't rely on them for tracking your progress.
Great, thank you very much. We're going to turn to Amanda now for a couple of questions. And first of all, how can we understand trends in our measures?
Sure, I think Bridget addressed this a little bit. There's going to be more information on our website this year in a measuring progress section. In addition, there'll be updated and expanded trend graphs available on our website that provide you with some guidance about the trend in each measure for your county and for the state and the nation. So you'll be able to, I think, more easily understand trends in the measures where we have trend data available.
Great. I'm going to turn back to Bridget for a quick refresher. You talked about the changes, what the methods for the behavioral risk factor surveillance system. We have somebody here asking for a little clarification. Will we be using the cell phone data in this year's measures?
The CDC created the measures for us using only the landline data. So if you, in your state, have county-level data available to you, we recommend that you look at that. Ours is comparable over time, but for other sources that might be available, please rely on those. We always say that the rankings are a starting point. Often your own sources of data may be able to give you more insights. And the other thing that for some of you who live in states, you may find that your state is able to actually calculate single-year estimates for you, whereas we are not able to do that. We're not able to provide that. So,
great. Thanks for that clarification. I'm going to turn back to Amanda. The data that we have, do we have data for more local areas or population subsets? We hear that question quite often from people.
So we don't calculate any of our data at either local areas smaller than counties or for population subsets of those counties. However, this year we'll be adding more information for states and the counties within it to enable them to see locally available sources of smaller areas or population subsets of measures like our measures. So hopefully that'll help counties looking to dig down into their data even more.
Great. So we've learned about some changes and new improvements to our measures. Have these changes resulted in dramatic changes to the rankings?
Actually, we didn't find that the additions of these measures caused overall more movement than we've seen in prior years of rankings. That's not to say that individual counties won't see significant changes due to the additions of these measures. So you may experience
small numbers of counties may see significant changes, but in general, they're not moving around that much.
No, I think what we're finding is that we're conceptually gathering the same types of data. We're improving our measurement of those concepts.
Great. We've had questions about the more technical specifications for measures. How can people learn more about the technical specifications for each measure?
Sure. So we provide a lot of documentation of our measures on our website. You can find it mostly under two tabs, the data description tab or the data sources tab. Most of the information you need should be there, and we're always striving to improve that documentation, so hopefully the 2014 will be even better. However, if you have specific questions, you're more than welcome to contact the County Health Rankings, and we'd be happy to help you understand the data even better.
And throughout our website at countyhealthrankings.org, there are bright orange buttons that say need help. If you click on that, the email comes right through to us, and we are pretty fast at getting back with responses. We slow down a little right around the release, but we still really try to get answers back to you in a very timely fashion.
For Amanda, can you talk about the data sources that we use for the County Health Rankings and the years of data that we're looking at for the rankings?
Sure. Our data sources, we probably use, I'm going to say 30 data sources to collect the data for all of our measures and additional measures combined. Those data sources are generally federally or nationwide sources of data that are available to the public, and we access those and put them into the rankings. In some cases, we get help from the National Center for Health Statistics and the Dartmouth Atlas of Healthcare to calculate specific measures for our specifically for the rankings. The years of data vary considerably from measure to measure. We always use the most recent data available, but that can vary from between, in the 2013 rankings, I think our most current data came from 2012, and some of the data that combines multiple years of data had to go back as far as 2005, I think. So it's important to understand that each measure comes from different years, and but we use the most recent data available.
And it's very clear on our website, the years of data that it's reflecting.
So if we're seeing some changes to our measures from year to year, how can communities compare their rankings from year to year?
Well, as I said before, we don't encourage comparing rankings from year to year. On the health factors side, where, as we've talked about, we do continually make improvements and try to produce better measures, that there are changes, and so it's a little like comparing apples and oranges in the health factors. The health outcomes, as I said, do stay the same in terms of the measures from year to year, but because of the reasons I discussed earlier about how one county's performance, well, one county's rank is both dependent on their own performance and the performance of all the others, we just encourage people not to use that particular approach, but to jump to look at the specific measures, and then you can make comparisons with other places. And in fact, on our website, we have a handy feature that's called Compare Counties that allows you to line counties up side by side to see how they are doing for specific measures compared to you.
So we had two questions that ask a little more specifically about two of the measures. For severe housing problems, we had a few questions about what actually makes up those measures. I know Bridget said it, but it goes by pretty quickly. So I'll say again, the four components of the severe housing measure are the percent of households that are overcrowded, the percent that lack plumbing facilities or lack complete kitchen facilities, and the percentage that have high housing costs, who pay more than 50% of their income in housing costs. Those are the four components of our severe housing problems measure. There was also some questions about what goes into our measure of injury deaths. Injury deaths contain intentional and unintentional injuries, falls, homicide, suicide, poisonings, drowning. Those are among the highest causes of injury deaths. So, I think we're getting a lot of questions about how counties will be able to see this data prior to the release.
And for that, we encourage you to contact your state team leads, and the names of those people are on our website, or send us an email via the website, and we will give you that information. Or steer you to the person in your state who can give you that information. There are a lot of questions that they're trying to go through, and as I said, we will try and we will answer every question. Some of you will get a direct response, and others we will post the general for the FAQ, which will be available on the webinar page. We don't do that for all of our webinars, but we know that we cover an awful lot of material in this one, and it is difficult to follow both my funny accent and the speed with which I talk. So that information will become available to you, but what they're trying to do right now is pick out the questions that are be of more general interest to everybody. So just hold with us. I think there's another question coming.
I'm just going to, I wanted to also update folks to let them know that slides for today's webinar are available online. I have sent a message out a couple of times with that link. That link will take you to the webinar page for today's webinar, and you will also be able to use that link later in the week when we have a recording of today's webinar available there. So if you're wondering if this webinar will be recorded and archived, it will be. You'll be able to find it on our website later in the week. And if you are wondering about slides, they are available now. So you're able to get online and find those slides.
And that same location is where the answers to all the questions will also be posted as well. That may take until into next week, but they will be coming. We also should point out that we have a couple of webinars coming up on other topics. So those of you who have been asking questions more about how do we move from data into action, those kinds of topics will probably be better addressed on other webinars coming up. Specifically on March 18th, 2 weeks from today, we have a webinar called Getting Your Rankings Message Out that will really help you think through the kinds of opportunities you might have with the release of the rankings to get the word out more and to raise awareness and encourage participation in your efforts to make your community a healthier place to live, learn, work, and play. That's on March 18th, that webinar. And then on April 1st, after our release, which is scheduled for March 26th, after that release, we will have what we call a County Health Rankings and Roadmaps 101, along with a website tour, which will go through by then the live website and show you just both the general organization of the site and then also some key tactics and strategies for really getting the most out of this wealth of data and tools and guidance to help you with your health improvement efforts. And it actually looks at this point like most of your questions are all so specific, and that we will handle those offline. And we really thank you all for your participation today. We hope that this was useful to you, and we hope that you're as excited about the 5th anniversary release of the County Health Rankings as we are. 3 weeks from tomorrow is the day, March 26th. So thank you all again.